Thank you. Thank you. And it sounds like I'm wired for sound here, so you can hear me pretty well. Yeah. I want to thank Aldo and the organizing committee for this really amazing day. We've learned so much, and I know that tomorrow we're going to have another wonderful day. I'm sorry to say that I won't be here because I have to get back to Mayo Clinic. We've just transferred over our health medical record, and we're in the throes of Epic right now. So, but I do specifically want to thank you, Aldo, for inviting me back. I think this is my 6th time in Canada. He calls me an honorary Canadian. And so I thank you for that and the confidence that you have. And so I don't have any financial disclosures, but I do disclose that I am from the US. And take that as you may. I will also say that I'm not responsible for the current political situation. And we only have a few more years to go. So we'll try and get through that. But through today, we have had a lot of exceptional speakers talking about myeloma and the side effects, and I really do love the concentration that we have about how the side effects, that the treatment aren't just what we're looking for. We're talking about the side effects and how we can live well with myeloma. We know that from our previous speakers that myeloma can cause side effects. We know that the different treatments can cause side effects, but for you, really, it all comes down to how do you feel? How is this affecting your life? We know that myeloma affects every aspect of your life, from the physical changes that you can experience, from pain to fatigue, the psychological aspects of anxiety, the social connections and networking, how it may impact your ability to work day to day. And if you're not feeling well, you're less likely to adhere to the therapy that is being prescribed to you. And if you don't get the therapy, you're not going to have the benefits of the really good therapies that are now available. And so what I really want to focus on today is the idea of how we can maybe try and prevent as well as manage. I'm not going to say get rid of all the side effects because I think that's a little too Pollyanna. But how do we manage these? How can we prevent them where we can prevent them? How can we promote shared decision making through discussions, conversations with your healthcare providers so that you can stay on track with your medications better? Having the conversations with them about the side effects that you may be experiencing. Is it time for a drug holiday? What are your questions and concerns? And then also putting a little onus on yourself, as you've heard from many of the other speakers today, about living well with myeloma and taking advantage of the things that you can as far as better living and healthier living. I think of mindful living. I stole this slide from Joe McHale. Thank you, Joe. But as we know that there are many components to managing myeloma, and whether you're one of our single star or multi-star people or one of our hearts, our caregivers, you have connection with all parts of these components, whether it's the initial diagnosis, maybe that transplant process or the consolidation if you're not eligible for transplant, maintenance therapy, and maybe you've reached a point where the therapy isn't working. You're at a relapse point or a refractory point, and I don't think they're the same thing. You can have a relapse on one therapy. That doesn't mean you're refractory to all therapies. But throughout all of that is this idea of supportive care, and that's what we'll be looking at. I'm not going to go into all of the specific details of every drug and every side effect that goes with each of these drugs because that would take all afternoon. And each one of you is probably on a different combination of these therapies, or maybe next month, next year, you will be on a different combination. So I will give you these 2 charts, which will be available, I'm sure, in the speaker notes of this meeting, of the different therapies and what the more common side effects are. But what I really do want to focus on as far as the treatment elements is this idea of steroids. And Dr. Bergstrom really had some fine answers to the questions that people already asked about steroids. You know all too well, or maybe the caregivers know all too well, how steroids, dexamethasone, prednisone can affect you, from mood changes to physical changes like weight gain. Small group of people actually lose weight on steroids because they aren't hungry, but the majority of people have a voracious appetite when they're on steroids. Maybe their blood sugars start to spike or go up when they're on steroids. There are a lot of changes physically that can happen. And so how do we keep you taking the steroids that are so important? Because we do know that prednisone and dexamethasone are one of the key components. And as Joe McHale had said, early on, especially when you're on a new therapy, it's like those boosters on the rocket. And Shaji Kumar, one of our colleagues at Mayo Clinic in Rochester, he actually did this study called Dex on Demand, starting people out on Revlimid alone and watching to see if they're responding. And he actually closed the study early because he found that people needed steroids up front to really get that synergistic benefit. So it's an important component, and so how do we be creative? Somebody already mentioned the idea of this sort of creative scheduling. Maybe you do take it before you go to bed, or come on, let's be honest, we all wake up at 2 in the morning and have to go to the bathroom. Have a little snack, take your steroids, sleep through some of those jittery things, and wake up maybe a little more alert. I know some of you that I've talked to today kind of like that steroid day because you got lots of energy. It's just your spouse who has to get through that day as well. And for that, some of those mood swings that can happen, there can be mood stabilizers. Maybe you need insulin while on steroids because your blood sugars are spiking. So there are a variety of things that we can look at, but one of the key things that I talk to people about so that you don't irritate your stomach is to eat a little bit when you're taking the dexamethasone, and for most people that's not too hard when you're on steroids. I do want to go into a number of side effects that I think are key to the therapies that you're receiving, and infections are one of the more life-threatening side effects that people can have, and I kind of list these, I think, more by my interest in medical and then more in quality of life, the way we'll go through these. But infection is the #1 cause of death in our myeloma people, and it's because myeloma does affect the immune system, just as described earlier today. Plus, the therapy can have an impact on your immune system. And those of you who have been through transplant know all too well about that plunging white count and getting into a state of neutropenia, big long word for just being more immunocompromised. And over time, your immune system is more compromised. The American Society of Hematology meeting this year had a couple of really key things that I thought were sort of low-lying fruit, easy to grab for us in the idea of how to prevent infection. One of them had to do with using the antibiotic levaquin or levofloxacin in the first 12 weeks of a newly diagnosed patient that really significantly reduced febrile or fever events and even death. And so I thought that was a key element that came out of that meeting, as well as the idea of influenza vaccines. You know, we do recommend that you get your flu shot every season, nothing live, no live vaccines. But the idea that they had a study that showed if you got your high-dose influenza vaccine and 30 days later repeated it, your titers stayed higher through the entire flu season. Now, they even recommended that maybe it should be longer than 30 days, but the idea that you can so simply improve your immunity and reduce your risk of infection, I thought was pretty significant. Now, when I mentioned the idea of immunizations, I don't think it's available here in Canada, but just recently in the last, I think, 4 or 5 months, we now have a shingles vaccine called Shingrix, which is available. Is it available here? Yes. Yay! It is a killed virus. It's an attenuated vaccine, which I think is a great opportunity to reduce that risk of shingles, which, as we talk about neuropathy, that is a huge part of neuropathy, or risk for neuropathy, is this post-herpetic neuralgia. And so I still am a big fan of acyclovir. It's probably one of the most cheap forms of insurance to reduce your risk of having shingles and then that sequelae of post-herpetic neuralgia. But in short, if you have fever, we consider that to be a medical emergency in the world of myeloma and immunocompromised people. Thromboembolic events, a really long word simply for blood clots. Now, it really depends on where that blood clot is that you may have symptoms. If it's in a deep vein in one of your limbs, like your arm or your leg, you may have swelling in the arm or the leg, maybe decreased blood flow, which is part of that swelling component, but you can even have change in coloring of your leg or your arm. If it's a blood clot in your lung, we call that a pulmonary embolism, and that might give you the sense of feeling short of breath. maybe a pain when you're taking a deep breath, maybe a sense of doom. All of these symptoms that might be of concern for a pulmonary embolism or a deep vein thrombosis, a blood clot, we consider that to be a medical emergency. And there are certain things that put you at greater risk for this. Simply having the diagnosis of myeloma puts you at risk of a blood clot. Being more sedentary, maybe overweight or smoking, having a recent surgery, combination, as we talked earlier about IMiDs like lenalidomide or Revlimid, along with dexamethasone increases that risk. So if you can imagine, newly diagnosed, your myeloma is active, maybe you found out by way of a fracture of your leg, you go in for surgery, and now you're kind of laid up after that fracture fix, and maybe you're still smoking. All of these things add up and increase that risk of having a blood clot. And now your newest therapy is Revlimid and dexamethasone. Well, there are some ways that we can try and reduce that risk. Obviously, if you're smoking, it's ideal that you don't smoke. Weight management, and I'm not going to sit here and tell you, or stand here and tell you, now that we put you on Dex, you're going to need to watch your weight. Let's at least try and be more mindful about it. But if somebody is on lenalidomide and dexamethasone, we do want to prevent a blood clot in the way of taking an aspirin, or if you've got a known history or family history of blood clots, that you might need to be on something a little bit stronger than an aspirin, like warfarin or one of the low molecular weight heparin injections. So there are a variety of things that you can do. Having just been on an airplane and jumping on one tomorrow morning, I take an aspirin before I travel. And I try to get up and I move and I pump my ankles and I do all those things, just like Joe made us do today, getting up and move a little bit. Some of the GI side effects. Now I've got diarrhea listed here, but I really believe that there's the two faces of GI side effects. You've got the diarrhea concerns, you've got the constipation concerns. And just like our last speaker was talking about how many of the narcotics can cause constipation, many of the drugs that people take can cause diarrhea. So let's say you've been on a number of narcotics because you've just been diagnosed from a vertebral compression fracture. Maybe you got radiation, the pain has gone away, but you're not needing to take the pain medicine anymore, but you haven't taken the stool softener out of your pill box, and now you're having diarrhea. Kind of take a look at what is in your pill box. Some of the complementary therapies can also result in diarrhea, things like milk thistle. Some of the antibiotics can cause diarrhea that you may need to be on. Some of it can be benign diarrhea, meaning it's just irritating, but antibiotics can also increase your risk of another infection called C. difficile or Clostridium difficile. And so if you're having diarrhea, it's important that you talk to your doctor about this so that you can check a stool specimen and make sure that there isn't this added infection or added issue that needs to be dealt with. Diarrhea can cause dehydration, and we sure don't want to make our kidneys unhappy or piss off our kidneys, and so it's important that you hydrate really well. So speaking of kidneys, we know that about 1/3 of people diagnosed with myeloma have this light chain component. Dr. Bergstrom was talking about the kappa or the lambda, the smaller light chain component of that immunoglobulin, and that can really affect kidney function. High calcium level when the bone is being reabsorbed can cause kidney dysfunction, or maybe you have some baseline issues from diabetes or other comorbid conditions. I hear the water glass is pouring. Cheers, everybody needs to be drinking. It's one of the best things you can do to reduce your risk of kidney issues, and of course getting the myeloma under control. Some people will need dialysis. Oh, I love this. Cheers. There's been a lot of discussion about peripheral neuropathy, and that's not by chance. That is a huge component of myeloma due to the disease itself as well as the therapies. And it's really one of the hardest to reverse. So it's important when we're thinking about peripheral neuropathy, first of all, prevention and how to manage it. it is difficult to reverse. And so if you are starting to experience any signs, any symptoms of neuropathy, you want to bring that to the attention of your provider early on. Velcade, it's often between cycles 4 to 6 that people will start to experience neuropathy. If you do have neuropathy, worsening neuropathy, we may have to adjust your medications and even go as far as taking you off. But the sooner we know about it, the better, so that if we can adjust the dose but still keep you on therapy, that would be ideal. Bone health, another large component of active myeloma is bone disease or defining events, myeloma defining events. About 85 to 90% of people experience some degree of bone involvement at some point along the trajectory of their disease process, and about 60% of people are diagnosed as a result of a fracture. So you've already heard some good things about how to help with bone health, from weight-bearing activity that was discussed earlier, the idea of good nutrition, and there are certain medications like calcium and vitamin D, the bisphosphonate therapies that will help to remodel bone. And there's, as Joe I think had mentioned earlier, the idea that that may have a benefit in reducing the risk of myeloma activity. So all of these are important components, and if you do experience any new acute pain, it's important to be talking to your doctor about that, because that could be an indication of maybe an active lesion. Even if the rest of your myeloma is well controlled, some people, years into their diagnosis, that is kind of the way they present with the relapse. Their serum, their blood counts are completely normal, and sometimes even their bone marrow is negative, but now they get a plasmacytoma in a rib, so a new lesion or a new myeloma tumor. And the reason that I say the neuropathy and the bone there is because that kind of evolves into this idea of pain management. And I think of pain coming from 3 primary sources in the world of myeloma: from the bones, from the neuropathy, whether it be from that peripheral neuropathy or that post-herpetic neuralgia that I was mentioning, and the idea of procedures. All of the procedures that we do, from blood draws to bone marrow biopsies, inserting a central line when you're going through transplant, all of these kind of things result in repeated pains. And if you only had to have one bone marrow biopsy in your life, fine, you know, but we know in the world of myeloma that's not usually the case. And so I'm a big advocate for sedated marrows, doing it sedated. I don't know if that's really an option for you all, but at Mayo Clinic, I'd say 80% of our people will have a sedated bone marrow procedure. And it's the other 20% that either somehow didn't know about it or they choose not to do it. But there are ways that we can deal with pain from the different things that have been discussed with narcotics, from cannabis. One comment, since I've got the podium, I'll take my little advantage here. I am not a disproponent of cannabis use. I don't like the smoking component of it myself, not for myself, but in general. From purely the infection standpoint, there is documented increased risk of aspergillus as a result of smoking cannabis. And you're already immunocompromised. Infection comes from bacteria, viruses, and fungus. And aspergillus is one of those nasty fungal balls that ends up in your lungs, and it is well documented in the use of cannabis. So that was my little soapbox. But there are different interventions that we can do, from surgical interventions to prevent a pending fracture, vertebrocompression fractures. There's something called vertebroplasty or kyphoplasty, where there's cementing of that vertebrae to help stabilize it and reduce that pain or even eliminate the pain. Radiation can be used, but we do that sparingly, because it's like burning the soil within that area of bone, meaning that bone marrow won't grow anymore. We don't want the bad stuff to grow, but it's not going to be growing the good components either. So we're pretty sparing about using that, but when needed, we will use that. And then, like many of the complementary therapies that were already discussed, and I'm a big proponent of activity when it comes to reducing pain. We've had some really good conversations already about the idea of fatigue, depression, and anxiety, and ways of dealing with that. And I'm not going to belabor it, partly due to time as well as that was already discussed, but I'm a big fan of the idea of that deep breathing, those of you who are in this breakout session this afternoon, the idea of the deep breathing, and really I focus on doing it like I take a deep breath and I'm sweeping out my brain and I breathe it out, and I breathe in and I sweep out my brain. Have you ever noticed that if you take medication and change one letter, it's called meditation? I just find that to be very curious and interesting. But I think there are a lot of ways that you can help to work through the ideas of fatigue from increasing activity, like the moderation that we were hearing about in our breakout session, to proper sleep hygiene, which again is challenging when you're on steroids, but working creatively with that steroid timing or schedule. Having a support network, coming to activities like this, as Aldo had said, about learning and being empowered through education. And as we transition into that empowerment discussion, which will be next, I just want to point out that there are a lot of educational materials available. Some here at the table, I saw those are really good. And then the International Myeloma Foundation has orderable items that are free as well. And so for the next component, and I think I'm a little bit on schedule, that I want to talk about the idea of shared decision making and health promotion, and look at the ideas of how you work with your multidisciplinary team, being mindful, and how that may help with health promotion and living well. When I think of your healthcare team, there are many people that make up that healthcare team, from a primary care provider to your general hem-onc person to maybe a myeloma specialist. All these people should be a part of your healthcare team, along with those subspecialists, maybe your orthopod and your infectious disease specialist, or your cardiologist or neurologist, plus all of the allied health staff, like your nursing staff and your pharmacy, not to mention the family and social support network that hopefully you have developed. But central to all of this is you and your caregiver. And it's always important that you remember you are central, and what is happening about you is most important to you. So you need to be the most continuous person in that dialogue and in that conversation. And so when you're meeting with your healthcare provider, and despite the fact that they want you to think you're their only patient and they've got all day to spend with you, they don't. And there's somebody else that's coming next that has many important questions as well. So I really encourage you to come prepared. Know what your priority questions are, your priority concerns are. Come with a list of things that have maybe changed since that last meeting, good, bad, or ugly, giving them an update. Make sure that they know what your current symptoms are, your current medications, and any supplementary type things that you're taking. And plan to take notes and ask questions. When you are at a pivotal point, maybe you know that you're having progressive disease and there's going to be a change in plan. Or maybe it's a time to be looking at, are we going to transplant or not? That you have somebody with you, another set of ears, another mouth to be asking questions, and somebody to help you take notes. Know that you're a consumer of your healthcare. You are central to this healthcare team. And it's important that you know that you can seek a second opinion, that it's important that you feel comfortable with the care that you're receiving and the care provider that you have. They may be the smartest and best doctor that everybody has ever recommended to you, but maybe you don't jive with them. Maybe you don't feel like you're being respected. Maybe that's not the right person for you. Maybe they're your best friend and they don't have a clue about myeloma. Well, maybe that's not the best person for you either. But it's important that you participate as a team member, being knowledgeable. I also don't want to, I flip that around also, and I don't want you to make yourself crazy and think you have to be the one that makes the final decision. You need to be a part of that decision making, and I truly would be relying on that healthcare professional to be most current on the information that is there. But ultimately, when it comes to that decision, you're the one who's going to be most affected, and so it's important that your choices are being thought of thoughtfully during this process. So when you're thinking about decision making when it comes to your treatment, I think there are a lot of things that need to be thought about. You know, are you eligible for a clinical trial? And it sounds like that's a way that many of you are able to get involved with or access to many of these really key new therapies. And even in the US, I really strongly encourage my people to participate in clinical trials, because I think you get very close monitoring, you get access to some really wonderful drugs up front, and it's how we got to where we are today in the world of myeloma from other people participating in these clinical trials. It's important that we're discussing what's important for you in the way of quality of life. Maybe it's 150 miles each way for you to get to an IV drug that needs to be given twice a week. Is that a realistic option for you? Maybe we need to be thinking about oral therapy versus IV therapy. Maybe it's not a newly diagnosed situation, it's a relapse, and maybe this is your second or third relapse. What has worked for you before? Maybe it's time that we revisit one of these previous therapies. And if time permits, always ask if you can stop and think about what options are going to be best for you. Have that time to consider the options. Discuss it with your provider. Be sure that you have a good understanding of what the ins and outs are about your plan of care. Same thing with transplant. The most current studies still support the idea of an upfront autologous or self-donated stem cell transplant after induction therapy for those people that are eligible. Allogeneic transplant, as discussed earlier, should only be done under a clinical trial. I know a number of people that are years out from an allo transplant, but it is not the frontline recommendation. But even autologous stem cell transplant is a commitment, and you have to know that going into it. I think it's very survivable. This is what I've been doing for almost 30 years, is helping people through transplant. But it is a commitment of going through the testing, going through the chemotherapy, and the supportive care that is needed for the first month after the transplant, and then that recovery time. And so it's important that if you have some negotiating space or the luxury of some time, maybe you're a school teacher and the best time for you to go through a transplant is during the summer. Maybe you're a farmer and the worst time for you to go through a transplant is in the summer. So really thinking about what it means for you in the big picture of quality of life. Now this is where I kind of put a little bit of that onus onto you as far as health promotion and health maintenance, because unfortunately having myeloma doesn't give you an out of jail free card for all the other things that can happen. And for some things, myeloma can increase your risk for other health preventable type issues. So it's important that you still see your primary care physician. You don't want your primary care doctor managing your myeloma. Don't have your myeloma specialist managing what the primary care can do. You want them to be able to focus on those important details that are specific to what their specialist's at. So seeing your primary care for blood pressure management, cholesterol, screening for cardiovascular and colon type things. Some people, people who have been treated for any type of cancer are already at risk for secondary cancers. So you still have to do the mammograms and the colonoscopies and the prostate exams and all of that. For people that have been on myeloma therapy, there is an increased risk for thyroid dysfunction. So it's important that every year you're having your TSH or thyroid cascade being checked. Steroids can cause cataracts to form prematurely, and as I had just mentioned, the idea of secondary malignancies. I've known a number of my patients that have had that experience, and it's just important that we're screening for all of that. Mindful living. I love the idea of mindful living, and it's not about, at least when I think of mindfulness when it comes to healthy living, it's, are you getting the activity that you can? There was a lot of discussion this afternoon about how much activity and what kind of activity. And one of the most key important things that I heard from the little lady that was up here is you need to find something that you enjoy doing so you keep doing it. Good nutrition is very important. Mental health, just as important as physical health. So again, that idea of meditation, social networking, those intimate relationships with your significant other or others, no judgment. Prevention of falls and prevention of injury. Let's say you've got neuropathy. Rugs can be your worst nightmare if you're not careful. Even a really hot bathtub water could burn your feet if you're not feeling it. So think of, and you've probably already done this, I know I'm preaching to the choir, but think of your world in a little different context. Infection prevention, risk amelioration or reduction in any way that you can. And the things that I'd like to say are easier: stop smoking. I know I've got my own addictive personality for food, that it's easier said than done, but do what you can. That idea being mindful, because people with myeloma are living longer. And it's not this 2 to 5 year survival rate for the majority of people. People are living, as you had mentioned, the idea of 10 and 15 years. And I've got a woman in my support group who's 27 years from diagnosis. I've got many people that I know that are more that I've known since I started my career at Mayo. And so I really strongly encourage you to look at the long term. I had a little lady, and actually Aldo knows this person, who when she was diagnosed, she thought she had 5 years to live, that was gonna be it. And so she took out all of her daughter's college loans in her name, figuring she'd never have to pay them back. Well, her daughter is 5 years out now, and she's still paying off her loans. So I feel a little bad, Cindy. Yeah. So, but think about this for the long term. So this idea of health promotion is not just to the myeloma survivor, but also to the caregiver. And it's so frequent that I see my caregivers not taking the time for themselves, feeling like it's being selfish to say that they need to be out, bowling. I was talking with a gentleman today who said his wife is out bowling today. And I love that idea. She's taking time for herself. And I think as caregivers, we feel that we need that permission. And even with permission, that doesn't work so well. I facilitate a support group in Rochester, and we do a caregiver breakout twice a year. I would do it more often, but my caregivers don't want to do it that often because they want to be with their person. And so you need to be doing the same healthful behaviors: good nutrition, mindful eating, activity, health maintenance, screening, all of those sort of things. Maybe keeping a journal or having some outlet for your fears and anxieties that go with this diagnosis. And don't be afraid to ask for help, because you're there to help somebody else, and people want to help you through this hopefully very long journey.